Good morning here from Washington, D.C., where American Thyroid Association meeting, the centennial year is going on. I am here at the meeting. This is your host, Ashok Bhaseen. I'm the president of Thyroid Federation International. So good morning, good evening, and good late evening in some parts of the world. Since it's a global seminar, we have people from all over. Please leave your questions till the end because, whatever questions you may have, some of those may be answered by the end of the webinar. So now I'll proceed to the next slide. So you're tuned in for the Thyroid Cancer Awareness Month, which is September. And today the topic is thyroid cancer patient journey and treatment modalities. The speaker is Professor Rossella Elisei from University of Pisa. I will be introducing her later. And also other speakers sharing the thyroid cancer journey are Beate Bartès from Toulouse, France, and Sylvie Deshaies from Quebec City in Canada. I will be introducing them later. Before we go ahead, I would like to thank our sponsors, Merck, Ipsen, Exelixis, Immunovant, IPSA, Horizon. However, none of them have any hand in this webinar. It's totally independent webinar, and just want you to go through the disclaimer. So thank you very much to our sponsors. You have all registered on your own, and we have not forced anybody to register. And this webinar is, as you see, the content of the information provided in the webinar is for your general information and use only. And if anybody needs to contact their doctors, please contact their physician or doctors for any information that you require. This is a presentation from an expert and sharing of a patient journey themselves. So nothing should be concluded from this. You should see your own physician for any follow-up or any recommendation. I would now like to introduce you to our speaker, Dr. Rossella Elisei, who is a professor at University of Pisa. She's one of the top Italian scientists also. She specialized in endocrinology, and her macro area includes biomedical sciences. She has done a postgrad doctoral research from Brussels and also been at the University of Cincinnati in Ohio. She's currently the professor at University Pisa in Italy in the Department of Clinical and Experimental Medicine. She has thousands of citations and lots of research behind her name. She brings deep knowledge and expertise in the thyroid cancer area and has been a recipient of many, many awards. So who better than to have Dr. Rossella? But I would also like you to be introduced to Beate Bartès. She's our own, she's a thyroid cancer patient, and she's from Toulouse, France, and she's the General Secretary of Thyroid Federation International. With her, you will also find another patient, Sylvie Deshaies from Canada in Quebec City. So over to you, Dr. Rossella, and welcome everybody to the webinar.
Welcome to everybody to this discussion about thyroid cancer. Thyroid cancer is a rather rare human cancer. As you can see here, it represents only about 4% of all human cancer. And it is at the 9th place in the order of incidence of this disease. It's a peculiar tumor. It prefers females, and the median age at the time of diagnosis is between 30 and 60 years, so the median age of the people. As you can see in these slides, females are affected 3-4 times more than males. Children are fortunately very few affected, especially younger children. In these children, thyroid cancer is fortunately very rare. When we say thyroid cancer, indeed we are talking about different types of thyroid cancer. It's not just one single type. Welcome. The most frequent is the papillary histotype, but then we have follicular, medullary, anaplastic, lymphomas, and as you can see in this picture, Papillary is indeed the most frequent, is about 65% of all thyroid cancer, but we have to consider that there are also other histotypes. And these histotypes have a different biological behavior. Papillary thyroid cancer is the one with the best prognosis. If you look at these slides that represent the survival of more than 1,000 patients affected by different histotypes of thyroid cancer, you can see that those with papillary thyroid cancer have a very long survival, a little bit less for follicular. The survival rate drop to lower rates for medullary, and indeed the most severe thyroid tumor is the anaplastic one. But if you remember the slide that I showed earlier, fortunately, anaplastic is only 1–2% of all thyroid cancer together. How is the presentation, the clinical presentation of thyroid cancer? Usually is a thyroid nodule. So that is apparently not different from a benign nodule. So when a patient has a thyroid nodule, the thyroid nodule should be submitted to a serious analysis, including the thyroid function with the measurement of thyroid hormones and TSH, neck ultrasound. Sometimes, not always, but sometimes could be helpful a thyroid scan. But the tool that allowed to distinguish benign from malignant tumors is fine needle aspiration and the analysis of the cytology. With this analysis, benign tumors that represent 95% of all thyroid nodules can be distinguished from malignant nodules that represent only 5% of thyroid nodules. Calcitonin is a serum marker that is important to be measured to exclude or identify medullary thyroid cancer. Calcitonin is the marker, the tumoral marker of medullary thyroid cancer. So in the workup of a thyroid nodule, including calcitonin will allow to exclude or diagnosis the medullary thyroid cancer, which is the surgical treatment of papillary thyroid cancer. In general, is thyroidectomy. Until few years ago, in any type of thyroid cancer, total thyroidectomy was the indication. Nowadays is a little bit different because if the nodule is localized in one lobe of the thyroid and the other lobe of the thyroid is normal and we can have this information with the neck ultrasound, it can be performed only lobectomy. Anyway, after surgical treatment, total thyroidectomy or lobectomy, patients should be followed and if needed, it could be treated with radioiodine therapy. Also, the radioiodine therapy in the last decades changed a little bit respect to the past. When I started this kind of work, all patients performed total thyroidectomy and radioiodine therapy. Nowadays is different, as I previously said, not only for surgery, but also for radioiodine therapy. And we have indications from the guidelines that, for example, in cases identified as low-risk patients, very low-risk patients, that means tumors that are small, less than 1 centimeter, without lymph node, without distant metastasis, there is no evidence that radioiodine therapy can be useful. So in this subgroup of patients, radioiodine therapy can be avoided. Then at the opposite, we have the high-risk patients. These are patients with a big tumor, the presence of lymph node metastases, and even more if distant metastases are present. In these cases, the radioiodine therapy must be done. And then there is a intermediate group in which the treatment may decrease recurrence, but the evidences are not definitive, and the decision to treat or not to treat with radioiodine therapy is based on clinical judgment of the doctors who are taking care of these patients. And another thing that has been changed in the last, this point, 15 years, is that the treatment with the radioiodine, which require a TSH stimulation, can be performed with the use, with the preparation, with the recombinant TSH. And this is very important because this treatment allows to avoid hypothyroidism, since before the era of recombinant TSH, to increase the TSH, endogenous TSH, patients should stop the treatment with thyroxine and became hypothyroid. Nowadays, this situation can be avoided with the use of recombinant TSH. And this is the survival curve of our patients, more than 4,000 patients with papillary thyroid cancer, and indeed also follicular thyroid cancer, treated in our institution. And you can see that after 35 years from the diagnosis, 94.5% of these patients were still alive. And this is to highlight that papillary and follicular thyroid cancer are, in general, with very few exceptions, are tumors, malignancies with which patients can survive, cured, or at least in some cases having a sort of chronicization of the disease. Even more important is the clinical behavior of micropapillary thyroid cancer. With these terms, we are talking about papillary thyroid tumors whose size is less or equal to 1 centimeter. It has been demonstrated that the survival probability of patients with a micropapillary thyroid cancer is even better than the probability of survival of the general population. What this means? This means that although it is a cancer, but from a clinical point of view, micropapillary thyroid cancer does not affect the survival of our patients. And this is the reason for which almost 30 years ago, our colleagues in Japan started an experience of active surveillance with this type of micropapillary thyroid cancer. They decided, with the agreement of their patients, of course, to do not operate immediately patients with micropapillary thyroid cancer, but to follow up them and send the patients to the surgeon only if there was an increase in size of 3 millimeter or more, or if the neck ultrasound showed the presence of lymph node metastasis. And as you can see in these two graphics, you can see on the left the percentage cases that increase their diameter during the follow-up, and you can see that after 10 years of observation, only 16% of cases showed this kind of increase, and they were sent to surgeon. But all the others were kept in active surveillance. So only a minor proportion of this micropapillary thyroid cancer are really growing. Even less is the percentage of cases that developed lymph node metastasis. After 10 years of observation, only 3.4%. And nowadays, this is a clinical practice that has been adopted in several referral centers, including ours here in Pisa Hospital, adult patients, of course. And if a patient has a thyroid nodule less than 1 centimeter and confirm that this is a papillary thyroid cancer, patients can choose to go to surgery, and if go to surgery, it will be submitted to lobectomy in the majority of cases, or to be submitted to active surveillance with clinical, biochemical, and ultrasound assessment every 6 months in the first 2 years, and then every 12 months. If there is increase of the size or the appearance of lymph nodes, the patients will be sent to the surgeon. So if so far we talked about rather in thyroid tumors, let's talk now about those minor portion of aggressive cancer, because they are few, but of course they are relevant in clinical practice. First of all, how many patients arrived at diagnosis already with distant metastasis? As you can see on your left, only 4-5% of patients with papillary or follicular thyroid cancer arrived at diagnosis with distant metastasis. All the others are, in the majority of cases, localized to the neck or just having lymph node metastasis. If we look at their survival after 5 years from the diagnosis, we can observe that group with distant metastasis have a survival rate of 55%. This means that the category of patients who arrived at diagnosis with distant metastasis have a risk to die within 5 years from the diagnosis of 50%. These patients can be treated with radioiodine. In these cases, we use high activities of radioiodine, and we can repeat the treatment several times to try to cure the patient. And in fact, as you can see on your right, patients with distant metastasis that are able to take up iodine, in this the upper part of the graphic, you can see that after 5 years, the majority of them, 80% of them, are still alive, while those who distant metastases are not more able to take up iodine have a more rapid survival curve, and after 5 years, more than 80% of these patients are already died for the disease. So the major concern in this subgroup of patients that, as I previously said, is very small but present in the clinical practice, the major problem is that when the radioiodine is not more able to cure the disease, we have to leave the treatment with radioiodine, suspend the treatment with radioiodine, and think to other type of therapies. At this point, we are talking of radioiodine refractory advanced cases, that they represent 20-30% of thyroid cancer who arrive at the diagnosis with distant metastasis. So very few if you consider that only 4% of our patients arrived at diagnosis with the distant metastasis. And then there is a small percentage of cases, 5%, that originates from the beginning as radioiodine refractory. These are called poorly differentiated thyroid cancer and are different from a biological behavior from papillary and follicular. So for many years, unfortunately, we did not have relevant therapies for patients with these radiorefractory tumors. But fortunately, nowadays we have a category of drugs named tyrosine kinase inhibitors that are very useful. These are small molecules that can be taken per os as an oral therapy, that from a point of view of their activity, they are competitive with the receptors that are activated in the tumoral transformation. These receptors that are altered in these tumors can be several. We have RET receptor, epidermal growth factor receptor, MET receptor, vascular endothelial growth factor receptor, etc. They are many, and they can be altered in neoplastic cells. So the tyrosine kinase inhibitors, here we have a list of several different types of tyrosine kinase inhibitors, are able to block the activity of these altered receptors. They are multi-kinase inhibitors because they can, each one of them can block different and several of these receptors. The two most important among all these groups are sorafenib and lenvatinib, and they are important because they reached the clinical practice. Nowadays, they can be prescribed to our patients with the radiorefractory thyroid tumors. This is the result of the decision study in which sorafenib was compared with a placebo, and you can see from this slide that patients treated with sorafenib had a significantly longer progression-free survival with respect to patients treated with placebo. Here in an example, just to show you the activity of this drug, this is with patients with poorly differentiated thyroid cancer treated with sorafenib before therapy, after 10 days from therapy, and after 20 days. This is almost unexpected, and the patient was not completely cured, but the disease could be controlled. And after this study, sorafenib was approved by FDA, and as I said, it can be used in these patients. We could not demonstrate the impact on the overall survival of these patients, but for sure we could demonstrate growth reduction of the disease. The other drug is lenvatinib. It's still an inhibitor of TKI receptors. You can see here the list of the receptors that lenvatinib can block. This is the schema of the study, the phase 3 trial that was performed a few years ago, in which patients were treated with lenvatinib or with the placebo, and this is the result, the curve showing the result. In orange are patients treated with lenvatinib, in yellow patients treated with placebo, and you can see that there is a big, huge difference in the progression-free survival that was much better in patients treated with lenvatinib respect to those treated with placebo. Again, we could not demonstrate an impact on the overall survival, but for sure, and we could demonstrate an impact in the control of the disease. This is just to show you the drug. They are capsules, 2 different dosage, 10 milligrams, 4 milligram. Usually we start with 24 milligram per day, but then we can adjust the therapy according to the single patient tolerability and adverse event. Which are the patients that should be treated with this kind of therapy, and when is the right time to start multi-kinase therapy? First of all, we have to demonstrate that the disease is radiorefractory, as I previously said. Here are the 3 major indications, but in general, we need to have either a disease that cannot be cured anymore with radioiodine, either because the lesions do not take up radioiodine anymore, or even if they take up radioiodine, but they grow during the time between 2 different courses of radioiodine. Once the disease has been demonstrated to be radiorefractory, we have to observe a progression of the disease, because these are cytostatic drugs. are drugs that mainly block the progression of the disease. So as principle, the disease should progress. And if the disease is progressing and radiorefractory, this is the time to start with the tyrosine kinase inhibitors. In particular, if the progression is of several lesions and not only of one single lesion. In this last case, we can also use local treatment or watch and see. And we are helped in this decision also by the serum marker of our disease, that is the thyroglobulin. We can measure the thyroglobulin of our patients in the blood. If the value of thyroglobulin is stable, it is very likely that the disease is stable, and then we can just observe the patient with an active surveillance. While if the thyroglobulin is increasing and increasing rapidly, for example, if the value doubling time is less than 6 months, at this point, we have to increase also the imaging to control the tumor growth. And if the imaging show progression of the disease, this is the time to treat our patients. Of course, there are cases in which we do not attend the demonstration of a progression because the disease is so diffuse that it's time to start directly without waiting for the progression. Recently, another drug has been tested in these patients, that is cabozantinib. This is the design of the study in which cabozantinib was used in patients who were previously treated with sorafenib or lenvatinib or both, and who entered into progression despite this therapy. So this was a study to demonstrate the efficacy of cabozantinib as second line. And these are the results. You can see here on the left the progression-free survival curves of patients that were treated with cabozantinib or with the placebo, and you can see the big difference. Again, no difference for the overall survival. And these are the different progression-free survival curves in patients who were previously treated with the sorafenib, or in the middle with the lenvatinib, or on your right with lenvatinib and sorafenib. And you can see that there was a great benefit in all of them, thus demonstrated that cabozantinib can be prescribed as efficacy as second line. So why we should be so careful in prescribing these drugs, all these type of drugs? Because unfortunately they have several side effects. This is the list of the side effects of sorafenib, and you can see that if you look at the grade, any grade of these different types of side effects, some of them are very, very frequent, and they are also impairing the quality of life of our patients, like, for example, the hand and foot skin reaction or the hypertension, etc. And these are the adverse events of lenvatinib. The types of adverse events are always the same. What is changing is the prevalence. For example, for lenvatinib, the most frequent adverse event is hypertension, while for sorafenib is the hand and foot syndrome. However, because they are unpredictable and any patients can have or cannot have the adverse event, or they can have one of them, not all of them, of course we have just to start therapy and then take care to control this adverse event. The reason for which these drugs have this adverse event is because they are strong antivascular endothelial growth factor receptor anti-angiogenic drug. So in the last few years, a new class of tyrosine kinase inhibitor has been developed, which are very specific for specific receptors. And there are 4 of them that are already in clinical practice, that are larotrectinib, entrectinib, selpercatinib, and pralsetinib. Larotrectinib is acting against NTRK fusions that are very frequent in several human tumors, including thyroid papilla, in particular papillary thyroid cancer. Here is the study demonstrating that larotrectinib is active in thyroid cancer here in green and indicated by these arrows. In thyroid tumors harboring this type of fusion. Larotrectinib has very few adverse events and rather different from the other tyrosine kinase inhibitors, and are side effects that can be easily managed by clinicians. Entrectinib, very similar to larotrectinib, is against NTRK, but also against ROS1 and ALK gene rearrangement. And again, some thyroid tumors here in yellow indicated by these arrows were treated with this drug with success. But these drugs are also able to reinduce the ability to take up iodine. This is only a case report. There are no clinical trials on this specific issue, but these clinical cases demonstrating that this is a possibility, and if we can demonstrate that this is for many other patients, in the future we probably can combine the treatment with the larotrectinib and radioiodine also in patients who were radiorefractory. The major problem is that these rearrangements are very few in papillary thyroid cancer. Only 2-3% of well-differentiated thyroid cancer are harboring a TRK fusion. But we have to find this small subgroup of patients because they can take a great advantage from these therapies. Then selpercatinib, that is a potent and selective RET inhibitor. These are the results of the in vitro and in animal models studies. And the studies performed in humans, more than 500 patients treated with this drug, either medullary, but also papillary thyroid cancer with RET fusions, and even some non-small cell lung cancer that can harbor the RET rearrangements. And these are the results on papillary thyroid cancer. You can see here even different histotype of thyroid cancer. Papillary in blue, poorly differentiated thyroid cancer in yellow, anaplastic, and also uterine cell thyroid cancer. And you can see that all patients treated with this drug had an answer to the drug, better or lower, but all of them respond to the therapy. Again, these arrangements are very few, 6.3% of well-differentiated thyroid cancer, but we have to find these patients and treat them with this drug. Also, these super selective inhibitor can reinduce the ability to take up iodine. And also for this drug, the future will tell us if we can combine the two treatments in our patients. Very few adverse events, and if present, they usually are grade 1, grade 2, so very manageable. And the drug has been approved for the treatment of these selected cases. Similar to selpercatinib is pralsetinib, that is a RET inhibitor, but it is able to inhibit also other TKI. These are the results in papillary thyroid cancer and medullary thyroid cancer. And again, you can see that all patients had a response to the therapy. Very few adverse events, and mainly grade 1, 2. Only 4% of patients discontinued the drug for adverse event. And the pralsetinib has been approved in the United States. Unfortunately, it will never reach the European countries because when the phase 3 study was, let's say, built or organized, unfortunately, selpercatinib was already approved. And since the two drugs are very, very similar. There is no reason to continue the research for pralsetinib because if a patient failed the control of the disease with selpercatinib, we cannot use pralsetinib because they are very, very similar. So to conclude this long story, we can say that there is not one thyroid cancer, but many thyroid cancer with different biological behaviors. The paradigm of thyroid cancer treatment has been changed in the last decade. Low-risk thyroid cancer can be minimally treated or not treated but followed. Advanced thyroid cancer should be firstly treated with radioiodine, and half of them can be cured. Radioiodine refractory advanced thyroid cancer, that, as I said, are fortunately very few, can now be treated with tyrosine kinase inhibitors, sorafenib or lenvatinib, and cabozantinib as a second line. And the new tyrosine kinase specific inhibitors are becoming viable in clinical practice with the advantage of very few adverse events. And thank you very much for your attention.
Hello, my name is Sylvie from Quebec, Canada.
Hello, I am Beate from France.
So, hi Beate, when and how was your thyroid cancer diagnosis?
Well, I had a goiter for several years, but with normal blood values.
Okay.
And one day my doctor said, well, we can make an ultrasound, and that's how they found 4 nodules. And for the beginning, we tried just to give some levothyroxine and to watchful wait. But a few months later, they had grown. It looked a bit suspicious, so it was decided to do surgery. My family doctor sent me to an endocrinologist, and then we decided to see a surgeon and to do a thyroidectomy.
Okay. Well.
And you?
Well, we have to go back in 2004. I had a complete checkup for my diabetes, and the doctor recommended that I see an endocrinologist for my thyroid. At this time, I knew that my blood test was good, so I said, I think I'm okay. He said, no, but you have a goiter, which I didn't know at this time. It was how I discovered the goiter. So I see the endocrinologist, and then I first had a scan of the neck, and when they see the nodule was 5 centimeters, and they decided to do additional tests after that. But what was next for you?
So for me it was surgery, so total thyroidectomy, programmed in June 2000, so 23 years ago.
23 years, okay.
And first they told me when I woke up that it looked benign, but 1 week later I got a phone call from the surgeon asking me to come in and to discuss. And so I knew something was wrong, and they had found cancer in 3 of the 4 nodules. And for you?
Well, for me, the next step after the scan of the neck was a biopsy. And it didn't show something wrong. It didn't show a good result, so they decided to go for a partial thyroidectomy. Just the lobe that was, where was the nodule, the right side. In November 2004, that's when it happened. How did you learn the diagnosis?
Well, it was on when the surgeon called me in person on the phone. He only wanted to give me an appointment for the next day, but I said, well, if you call me in person, then I guess there's something wrong. And he said, yes, but don't worry, it's totally curable. You don't even have it anymore because everything has been taken out. So he was very reassuring. But I learned it on the phone, but in a very human way. It wasn't such a big shock.
Yeah, it was a few weeks after the surgery. I received a call from the assistant of the otorhinolaryngologist who did the surgery. She wanted to see me, so I said, okay, something's wrong, something's going wrong, I'm sure. My husband was with me, so we met in person, the ORL, and she explained to me that I had a papillary carcinoma and I need to go back on another surgery to complete the thyroidectomy, yes. In fact. So that's how it happened. How were you feeling when you received that diagnostic?
Well, of course, the word cancer is always a shock, but I think I'm really very lucky because when I was first diagnosed with the nodules, I went on the internet, and 23 years ago there was very little information on the internet, only very technical pages for doctors, but nothing for patients. There were no patient portals and things like that. But I found a very small website created by a German patient, because I'm German. It was a cancer patient who had created a small discussion forum for patients. So I had the occasion to discuss with other patients who had nodules, who had cancer, who had gone through the treatments. And so I knew that how thyroid cancer was treated, and that it's a cancer which normally is very well treatable, and with treatments which were less difficult to cope with than for many other cancers. And so I wasn't that afraid, and I knew that I personally knew, at least via the internet, some other patients who had cancer and who were cured. So
Yeah.
I wasn't really afraid. I was convinced that I could be cured too, and so it wasn't such a shock. But still, learning that you are concerned is hard. How was it for you?
Yeah, it's pretty similar. Hearing the word cancer is a shock, of course, and we're always thinking of the bad, which is not the case for this one. But of course, I was nervous about that, and the most effect it had on me, it was the fact that I was not talking about someone that I know. I was talking about me. Now it was my turn to be part of the statistic, if I can say it that way. But I had good support from family and friends. But of course, it was a shock for me and for them also. And how did the doctor explain the situation for you and make it easy to understand the journey you were going to?
Yeah. Well, the doctor had already planned the appointment when he found me, so I could come in the next day and ask all the questions I had. And they explained to me how it would go, that now I had to stay without hormones for a few weeks, and then I would have radioiodine. But what helped me most is that I had already discussed with other patients, so I already knew about it. I knew what radioiodine is, and that it's different from chemo and X-rays and all that things. So it was really helpful to have been in contact with other patients.
For me, it was, I'm lucky. I used to say that I'm very lucky because the ORL was very human. She took time to sit beside me. She wrote on a paper some suggestion of website to consult and to take time to absorb the news and to read a few hours just to read more on this. But she was just with me, beside me, very calm, very. She made it easy for me because she reassured me. She was
I remember.
very human. I'm lucky with that. Yeah.
I think I'm also very lucky because my endocrinologist, I had his email, and I remember.
Wow.
No, it was a fax. I didn't have his email, but I remember sending him a fax with all my questions, and he found me to explain all those questions for half an hour.
It helps a lot.
That helps really a lot. Yeah.
Really. And what was your treatment?
So first I had surgery, and for me, as I had 4 nodules, 2 on each side, it was total thyroidectomy from the beginning. But I didn't have a biopsy before, so first we thought it would perhaps be benign, finally it wasn't. And 6 weeks later I had radioiodine. And then I had 1 year after and 2 years after, I had a whole body scan with radioiodine again to check that everything had gone. And 2 years after I was declared cured.
Mine was pretty similar. After the second surgery, I got radioactive iodine treatment. A year after, I had another, not another treatment, but I had it under thyrogen.
Whole body scan.
Yes, just to validate. And what was the most difficult for you?
For me, the most difficult was not the surgery went well and was quite easygoing. I had already had other surgeries which were much more difficult. Doesn't hurt that much, and I could leave the hospital the next day, so it wasn't that bad. But what was really difficult was the preparation for the radioiodine treatment, because at that time, 23 years ago, the recombinant TSH didn't exist, which you can just inject. So you had to stop your hormone treatment and to wait for your endogenous TSH to raise, and that takes several weeks, and you are really hypothyroid. And I felt very tired, very depressed, no energy for nothing, and I had three young kids, a husband. I was working. That was really hard. I was a technical translator, and I remember I couldn't concentrate. It was really dangerous driving my car, because I really couldn't concentrate. My reactions were really slow. So that was really the hardest time. The weeks before and after the radioiodine treatment, the time to take your hormones and before they are really efficient again.
I recognize myself in that journey too. The first part that was difficult for me was the biopsy, because I'm afraid of needles, so it scared me a lot. I made some nightmare about it, but it went very well. ORL was very, very good. And the next one was, like you, preparation for the radioactive iodine treatment was very difficult. I felt so weak, always tired, like you mentioned. I had a blank in memory, couldn't remember names that I'm using every day, and no energy, like you said. It was difficult to concentrate, feeling sleepy all the day, and having difficulty to take decision also. It's strange for me that it was part of my job at this time. So I said, "Oh, what's happening to me? Who is there? Who am I?" And now, how are you managing your life?
Well, in the beginning, it took a bit of time to recover from the hypothyroidism, to find the right dose of the medication. So first we had to raise it several times so my TSH would be suppressed, like you need after cancer. But it took a few months, but since then I live a perfect normal life with my family, work. So I'm back to normal again. It was a hard time, but I'm fine.
It's pretty the same for me. The first year was difficult just to find the good part, medicine, the good way to prescribe the medicine. But now I'm okay. I'm back to normal life, like you said. I'm doing all my regular activities like walking, hiking, biking, and even traveling to see my friends in France. Yes, and now how did you find more information and education on thyroid back in time?
Well, back in time it was really complicated because there were no patient websites, patient portals, understandable information. I think even Google didn't exist in 2000, so it was really difficult. It's much easier for patients now, but perhaps it's not that easy because you find so much information that it's difficult nowadays to know what is right and what is wrong, because there's all sort of information out there. But in that time, there was really very little information, and I'm really lucky that I found this German website created by a patient, which is called Ohne Schilddrüseleben, which was at that time a very small forum. Later it became an association, and it helped me so much to go through this journey that once I recovered from the radioiodine treatment and the hypo, I decided to create the same thing in French with the help of the German patient, who is still a good friend. And so in October 2000, 2 months or 3 months after the radioiodine treatment, when I was back on track, back in work, I decided to create a forum for patients in French, which is called Vivre sans thyroïde, and which later became an association. It was very small in the beginning, only a few patients per day, but now it has 4,000 to 5,000 visitors a day. But it's about all thyroid disease, not only thyroid cancer. But apparently, even for all those other patients, it's very helpful to be able to discuss with other patients, learn from their experience, find emotional support. I think that's really important, so that you don't. It's a quite rare cancer, so you don't meet patients who had it around you normally, and it's really helpful to not to feel alone.
And I can confirm, because that's how I met you. I find out my information and support at Vive Sans Thyroid that a few weeks after having the diagnostic, a friend suggests me, found that for me on the internet, and he suggests me your forum. That's a good place of information and a great community to support each other. This is true. Fantastic.
Yeah, and that's also why, how we are here now today, because it's for Thyroid Federation International, which unites patient organizations all around the world, on all continents. We are nearly 40 organizations now who meet, who exchange, who learn from each other's experience to give help to all patients around the world. And we hope to spread out even more.
Thank you.
Thank you. Goodbye.
Goodbye.
Hello, this is your host, Ashok Bhaseen, President of Thyroid Federation International. You just heard Beate Bartès and Sylvie sharing their patient journey, and I think you can relate to that. So we are almost out of time. There are some questions which I've already answered, and you will get direct email for those answers from us. And I would like to thank each one of you for joining and attending the webinar today, the second webinar of Thyroid Cancer Awareness Month, September month, 2023 this year. And I would like to thank Dr. Rossella. Despite a very busy schedule, both Dr. Rossella and me are busy here at American Thyroid Association in Washington, DC. It's a centennial year, so we just took the time to make this happen. And I will also like to thank our sponsors, Ipsen, Exelixis, Horizon, IPSA, Immunovent, Merck KGaE, MD Serono, and also Jamie Nisbet of Codominio to put this webinar together. And stay tuned for more webinars in future. And this is your host, Ashok Bhaseen from Washington, DC today, attending the American Thyroid Association Centennial Year. So thank you very much for tuning in, and wish you all the very best, and you will hear more from us. Thank you for coming today and joining the webinar. Bye for now.